we're going to continue our discussion of joints and deal now with other structures that help to minimize friction. And essentially when we're talking about this, we're talking about possibly our friend the bursa. And what's the bursa? If you go to university, it's a place that takes your money. But here, we're thinking about these sacks, as you can see them in green here. So here's a bursa, here's another one. So any of these green things. And within them is synovial fluid, so there's synovial fluid within it to help minimize friction. And basically, wherever you have something that's going to overlie a bone, so I kind of have listed here ligaments, muscles, skin, tendons, wherever they kind of overlie bone, you're going to have a bursa. There's also, because it's in the image, if let's say you have a tendon, because we know tendons connect what? Muscle to bone, that around the tendon you'll have a tendon sheath. And I bet if you irritate it, what would you get? A case of what? Tendinitis. So that would not be too good. So you're having some inflammation going on there. Now, what else do we have? Well, sometimes if you do have inflammation, things can get problematic. And one case is, you never think of a bunion, but a bunion is actually inflamed bursa. It's swollen, and by being swollen, it actually will mess up the positioning of the bones. And you think, well, no, it doesn't happen that way. I was like, oh yes, it does. This is, ouch. That's not going to be good. You like my handwriting with this stuff? That's going to hurt. So see a podiatrist, not a proctologist. I know they both start with P, but that's could be a definitely different issue there. So just be careful. Go to a right specialist to take care of these problems. What else can we talk about besides what happens when things go wrong? We could hit briefly joint strength. We already said that joints are the weakest part of the skeleton, so what does give them the strength? Well, first thing is the surface, and we get into some basic issues. The deeper the socket, the greater the stability. So in other words, the price you pay for stability, you lose mobility. So the greater the stability, the lesser the mobility. And the opposite is true. The greater the mobility, the lesser the stability. In other words, where you have, let's say, the glenoid cavity articulated with the head of the humerus, that's rather shallow. It's the most movable joint in the whole body is your shoulder joint, but also it's the easiest to disarticulate relative for its size, as opposed to the hip joint, which is the deepest, and if you disarticulate that, oh, that must hurt. What else? Basic rule, the more you have something, the better off you are. The more ligaments, the stronger it is. But ligaments are like the taffy of the body. So in other words, if you slowly put a lot of force in them, give it enough time, it will stretch. And if it stretches, there's no turning back on it, surgery. Or, think about taffy, if you hit it real fast, pull on it real fast, it could snap. So ligaments do have that basic characteristics there. What else? Muscle tone. Turns out muscles are always partially contracted. And remember, bones connect to bones via ligaments. Muscles connect to bones via tendons, but literally doesn't one muscle connect two bones together. So the muscles are always kind of contracted through muscle tone. That also helps to further give you some strength on the joint. This video is going to be actually a bunch of little things. So we talk about associated structures to reduce friction. Now we're going to talk about types of movements, and then later we'll go into synovial joints in detail. Now, I don't necessarily have pictures of all of these, so you just have to kind of use your imagination. But with types of movements, we have the simplest movement. It's called gliding, and that's kind of doing the hand wave, not where you kind of bend up and down, but just kind of side to side. And this is where your short bones, remember, like your tarsals or your carpals, slide past each other. They slip past each other. Then you have angular movements. You change the angle between two bones. A flexation is a decrease in the angle, and extension is an increase in the angle. And you just have to kind of look in the book for some pictures of that. But like when I flex my arm, I'm bringing my arm and decreasing the angle there. If I raise my hands, that's actually a flexation, it turns out, because you're measuring the angle between the arm and the shoulder. That's a flexation. Here we have one, we have some special ones. You have dorsiflexation versus plantar flexation. I think of plantar flexation, which I'm going to plant my toes down. Now be careful, because both words deal with flexation. So you have to be careful which one. So a plantar flexation, you're most likely a ballerina. Dorsiflexation, well, something else may be happening. But dorsiflexation, the toes point up. Plantar, the toes face down. Rotation, here we got Linda Blair as an adult. We can rotate the head. You do the arms, the legs. You can rotate it outward or inward, medial versus lateral. So there's all types of rotations. And why are we doing this range of motion again? Because when you got a patient and they're needing some physical therapy, there's a right way to move them and the wrong way to move them. If you do them the wrong way, you're going to do them a disservice and harm. You want a cup of soup? We call that supination. Supination, basically the radius and ulnar are, if you look at this, parallel. When they cross over, we call that pronation. With supination, the palms are facing anterior and superior. Again, you just have to kind of act out. That's more anatomical position. Now, I know I skipped AB and adduction. I wasn't sure if I was going to see a picture of them. But abduction, you're moving your fingers away from the body midline, the arms away. B doesn't face the A. It's facing away. You're spreading apart. AD, you're adding together. The D faces the A. You put your fingers together. You put your arms at your side. Those are all adductions. If you kind of do a combination of flexation, extension, AB, adduction, you may be doing circumduction, which you're drawing a cone. And the base of the cone is where your fingers would be, and the apex, the tip of it, would be right at your shoulder joint. If you look at the top of page 13, the last 3 sets, and then that'll be the end of this video. You have IN inversion versus eversion. Evert, outward. Eversion, the soles turn laterally, while inversion, it turns more medially. And this is obviously not an easy movement unless you, I guess you're a dancer. Hey, Ma, no dentures. Retraction, you kind of move the mandible posteriorly. Protract, you move it more anteriorly, or you jut it out. Let's see. Anytime you're going to raise things, we call it elevation. So you can elevate your mandible, elevate your shoulders, and then, oh man, was there a test? I'm depressed. Well, anyway, that's depression. Mandible goes down, shoulders go down. And I think that takes care of these movements.